and later we will discuss what are the do's and don'ts in these cases. My first case is about a 35-year-old female who underwent ASD patch repair at her 22 years of age back in 2011. Her pre-procedure echo showed that she had ASD secondum measuring 19 into 17 millimeter with left to right shunt and dilated RA-RV, and at that time calculated PSP was 55 millimeter of mercury. No cardiac catheterization was done at that time. For last 2 years, she had been experiencing progressive shortness of breath and easy fatigability. Functionally, she was NYHA class 3 and also complained of palpitation. On examination, I found her mildly dyspneic. Saturation was 98% in room air, and she preferred propped-up decubitus. She had features of right heart failure, and on auscultation, her first heart sound was audible in all 4 cardiac areas. Pulmonary component of second heart sound was loud, and there was an early diastolic murmur at her left upper sternal border. Her ECG showed that she had sinus rhythm with normal axis, features of incomplete right bundle branch block, and right ventricular hypertrophy with strain. Her chest X-ray showed she had cardiomegaly, RV-type apex, bulged pulmonary conus, and prominent vascular markings at her right hilum. Her echocardiography shows she had intact ASD patch with no residual ASD flow, and in apical 4-chamber view, she had normal chamber dimension with features of right ventricular hypertrophy, and she also had moderate RV systolic dysfunction. Her calculated PSP was 75 millimeter of mercury, and she also had mild pulmonary regurgitation. So this was a case of 35-year-old female who underwent ASD patch repair, now having no residual ASD flow, but patient had persistent severe pulmonary hypertension with moderate right ventricular systolic dysfunction, good left ventricular ejection fraction. Now moving on to my second case. This is a case of a female patient, 44 years old, and she presented to us with effort intolerance and palpitation. Functionally, she was NYHA class 3. She also presented with occasional episodes of hemoptysis. On examination, we found her mildly dyspneic, saturating 88% in room air. Her first heart sound was audible in all 4 cardiac areas, and pulmonary component of second heart sound was loud. There was no audible murmur. On her chest X-ray, she had cardiomegaly, right atrial enlargement, RV-type apex with a bulged pulmonary conus and multiple end-on vessels on both lung field. Her ECG showed sinus rhythm, incomplete right bundle branch block. In her echocardiography, bicable view shows ASD secondum measuring 26 into 22 millimeter, which is shunting bidirectionally. And in the apical 4-chamber view, she had dilated RA-RV with hypertrophied RV, and also she had mild RV systolic dysfunction. Her calculated PSP was 85 millimeter of mercury. We have done cardiac cath in this patient, which showed that her PA pressure was very high, 80/40, with a mean 53 millimeter of mercury, and there was no change in PA pressure after giving 10 minutes of oxygen. Her calculated QPQS ratio was 1.46:1, and which increased very little bit to 1.5:1 after giving oxygen. PVR was very high, 7.54, and which came down to only 6.79. PVR-SVR ratio 0.36, which went down to 0.3. So this is a case of large ASD secondum with bidirectional shunt, having severe pulmonary hypertension, mild RV systolic dysfunction, high PVR, which did not change after giving oxygen. So in these 2 cases, we want to thank you, Mymuna, for your excellent presentation. Yes.